The question, what will help with my vertigo? Vertigo is usually due to a disturbance in the vestibular system. The vestibular system is one of three sensory systems subserving spatial orientation and posture. The other two are the visual system, retina to occipital cortex, and the somatosensory system that conveys peripheral information from skin, joint, and muscle receptors. The three stabilizing systems overlap sufficiently to compensate, partially or completely, for each other's deficiencies. Vertigo may represent either physiologic stimulation or pathologic dysfunction in any of the three sensory systems. Physiologic vertigo. This occurs in normal individuals when 1. The brain is confronted with an intersensory mismatch among the three stabilizing sensory systems. 2. The vestibular system is subjected to unfamiliar head movements to which it is unadapted, such as in seasickness. 3. Unusual head/neck positions, such as the extreme extension when painting a ceiling, or 4. Following a spin. Space sickness, a frequent transient effect of active head movement in the weightless zero-gravity environment, is another example of physiologic vertigo. Pathologic vertigo. This results from lesions of the visual, somatosensory, or vestibular systems. Visual vertigo is caused by new or incorrect eyeglasses or by the sudden onset of an extraocular muscle paresis with diplopia. Based on the origin, vertigo can be also classified as central and psychogenic vertigo. Treatment. The most important diagnostic tool is a detailed history focused on the meaning of dizziness to the patient. The simplest provocative test for vestibular dysfunction is rapid rotation and abrupt cessation of movement in a swivel chair. This always induces vertigo that the patients can compare with their symptomatic dizziness. A final provocative and diagnostic vestibular test, requiring the use of Frenzel eyeglasses, self-illuminated goggles with convex lenses that blur out the patient's vision, but allow the examiner to see the eyes greatly magnified, is vigorous head shaking in the horizontal plane for about 10s. The evaluation depends on whether a central etiology is suspected. If so, MRI of the head is mandatory. Such an examination is rarely helpful in cases of recurrent monosymptomatic vertigo with a normal neurologic examination. Treatment of acute vertigo consists of bed rest, 12 days maximum, and vestibular suppressant drugs such as antihistaminics, meclizine, dimenhydrinate, promethazine, tranquilizers with GABAergic effects, diazepam, clonazepam, phenothiazines, prochlorperazine, or glucocorticoids. If the vertigo persists beyond a few days, most authorities advise ambulation in an attempt to induce central compensatory mechanisms, despite the short-term discomfort to the patient. Chronic vertigo of labyrinthine origin may be treated with a systematized vestibular rehabilitation program to facilitate central compensation. Prophylactic measures to prevent recurrent vertigo are variably effective. Antihistamines are commonly utilized but are of limited value. Meniere's disease may respond to a diuretic or, more effectively, to a very low-salt diet, 1 gram/d. Recurrent episodes of migraine-associated vertigo should be treated with anti-migrainous therapy. Psychogenic, phobic postural vertigo is best treated with cognitive behavioral therapy.